Today we will discuss about the difference between the direct and indirect hernia. First of all, I have got the remove the anti-abdominal skin, and it is from the midline incision, as well as there is anti-superior iliac spine to the pubic tubercle and horizontal incision I have keep. After that, removing the skin, you can see here there is a two layers. It is fatty layer. It is considered as a uh, fascia camper, and the membranous layer, which is considered as a fascia scarpa. And both the layers, which is pierced by the cutaneous subcostal nerves, and it supplies to the anti-abdominal wall. After that, you can see here there is a muscles which is directed downwards, forwards, and medially. It is the external oblique muscles, and just below to these external oblique muscles, the another muscles which is goes upwards, forwards, and medially. It is the internal oblique muscles. Here you can see. I have also cut the keep the cuts from anterior superior iliac spine to the pubic tubercle and medial side of the thigh, and I will reflect the skin of the front of the thigh. Now I will show you this external oblique. This is the external oblique muscles directed downwards, forwards, and medially. This is the another muscles internal oblique, which is directed upwards, forwards, and medially. And just along with it, there is another muscles which is fuse fiber of the transverse abdominis. This is the muscles which is transverse abdominis, and the muscles fiber of transverse abdominis which is goes horizontally. And after this reflection of these muscles, you can see there is a fascia transversalis, and this fascia transversalis, which is uh, inside this fascia transversalis, you can see there is a gap, and this gap, which is uh, forms the deep inguinal ring. Here, that level, there is a gap, and this is the spermatic cord, and you can see there is a spermatic cord which is come out from the external oblique muscle, and this ring, it is called the superficial inguinal ring. And from this superficial inguinal ring, there is a passing the ilioinguinal nerves, and this ilioinguinal nerves which is supplies to the skin over the external genital, and it is a branch of L1. So here you can also see this is the ilioinguinal nerve, and you can trace it is the partial content of the inguinal canal. The lateral part which is not lies inside the inguinal canal, but the medial part which is lies inside the inguinal canal. Just above to it, you can see another nerve. It is the iliohypogastric nerve. But today, basically, I will show you the structure, and after that, we will discuss the difference between the direct and indirect inguinal hernia. On the medial aspect, I will show you there is a, I will keep the incision over the medial side, and you can see there is a rectus sheath, and I have got there is a transversely the rectus sheath. This is the level of the umbilicus, and just below to this level of umbilicus, you can see there is a arcuate line. This is the arcuate line, and just above to this arcuate line, all three muscles which is pass just above to this arcuate line, the anteriorly there is a passes above anterior to the rectus abdominis. There is a passing of the external oblique, as well as there is a anterior lamina of the internal oblique. Posterior to it, there is a passing of the posterior lamina of the internal oblique, uh, transverse abdominis muscles, and fascia transversalis, extraperitoneal connective tissue, as well as the parietal peritoneum. But below to this arcuate line, the anteriorly the fiber which is passes to the rectus abdominis are the external oblique, internal oblique, and transverse abdominis. All three muscles which is passes front side, but on the posteriorly you can see there is a only fascia transversalis or behind to the rectus sheath. So the posterior boundary of the rectus sheath below to the arcuate line, which is formed by the fascia transversalis, parietal extraperitoneal connective tissue, and parietal peritoneum. Here you can see this is the one artery which is considered as a inferior epigastric artery, and this triangle which is formed by the this triangle, this is the inferior epigastric artery. I will show you from this side also. Here you can see this is a inferior epigastric artery. This one is the inferior epigastric artery. Here you can see this is the inferior epigastric artery, and just lateral to this, here you can see this is a deep inguinal ring. So inferior epigastric artery, it forms the it forms the lateral boundary of the SL base triangle, and this laterally there is a SL base triangle which is bounded by the inferior epigastric artery. Medially it is bounded by the lateral border of the rectus abdominis muscles, and below it is bounded by the most lower fiber of the external oblique. It is the uh, from anterior superior iliac spine to the pubic tubercle, it is the lower part of the inguinal ligaments. So, whenever there is a even this Hasselbeck triangle further divided by the two parts by the obliterated umbilical artery. Lateral to it, there is a lateral part, and medial to it, it is called the medial uh, part of the Hasselbeck triangle. Now, today we will discuss about the difference between the indirect inguinal hernia and direct inguinal hernia. The indirect inguinal hernia mainly occur into the uh, congenital in natures, and it mainly it passes through the gap inside the fascia transversalis. It is the deep inguinal ring, and this deep inguinal ring, which is situated uh, from the mid-inguinal point, 1.5 centimeter above to the mid-inguinal point, and from this deep inguinal ring, the content of the spermatic cord, which is in content of the abdomen, which is passes along with the spermatic cord and come out with the superficial inguinal ring, and then it is pass inside the spermatic cord, pass through the superficial inguinal ring along with the spermatic cord. Then the abdominal content which is come out at this place from deep inguinal ring to superficial inguinal ring, it is called the indirect inguinal hernia. And this indirect inguinal hernia, which is uh, 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 covered by the, there is a continuation of the this skin, it is the skin of the continuous, and then this fascia, it is a fascia camper and fascia membranous layer, both are continuous as a dartos muscles and inside the scrotum, and also uh, it is the collis fascia. Another covering of the external oblique, it is continuous inside the spermatic cord as a external spermatic fascia. The internal oblique and transverse abdominis both together, it makes a conjoint tendon, and it makes the three boundary of the inguinal canal, lateral, superior and posterior boundary. Uh, Anterior boundary on the lateral aspect, it forms the anterior boundary. On the middle part of the inguinal canal, it forms a roof, and the medial side, it forms the posterior boundary of the inguinal canal. So this conjoint tendon, it is continuous inside the spermatic cord as a cremastic fascia and cremastic muscles, and it is a covering of the testis or covering of the hernia. After that, there is a fascia transversalis. It is uh, continuous as a, and continuation of this fascia transversalis, it is the continuous as a inside the spermatic cord as a internal spermatic fascia. So these are the external covering of the testis. So first one is the skin, then the dartos muscles, then external spermatic fascia. Dartos muscle, it is a continuous of these two membranes, fascia camper and fascia scarpa. External spermatic fascia, it is a continuation of the external oblique. Cremastic fascia, it is a continuation of the conjoint tendon, and it becomes the cremastic muscle and cremastic fascia. and fascia transversalis, it is continuous as a internal spermatic fascia. So these are the covering of the indirect inguinal hernia. And the direct inguinal hernia mostly occur from the Hasselbeck triangle, and it is uh, covered by the fascia transversalis. Uh, uh, First of all, the parietal peritoneum, peritoneal connective tissue, fascia transversalis. After that, there is a conjoint tendons, and then conjoint tendon contains the uh, um, transverse abdominis and internal oblique muscles, as well as it is covered by the external oblique muscles and this membranous and fatty layer of the anti-abdominal walls. So mostly direct inguinal hernia, which is inside the it is inside the Hasselbeck triangle. You have to remember always the infiepigastric vessels. This is the infiepigastric vessels which is always lies medial to the deep inguinal ring. So whenever there is a hernia from the Hasselbeck triangle, which is considered as a direct inguinal hernia, then it is passes medial to the infiepigastric artery. While the indirect inguinal hernia, which is passes from deep inguinal ring to the inguinal canal and come out through the superficial inguinal ring. While the femoral hernia, which is lies inside the femoral triangle, and this is the femoral sheath, anterior layer, and it is the femoral sheath which is three compartment. The lateral compartment contains the femoral artery along with the femoral branch of genitofemoral nerve. The intermediate compartment contains a femoral vein, and medial compartment it considered as a femoral canal, and it contains a femoral inguinal lymph node, deep inguinal lymph node. It is a Crockett and Rosenmonal lymph node, and this only lymph node contained into the most medial compartment. It is called the femoral canal. Whenever there is a abdominal content come out from this most medial compartment of the femoral sheath, then it is considered as a femoral hernia. And always you have to remember femoral hernia which is lies below and lateral to the pubic tubercle, while the inguinal hernia always lies above to the pubic tubercle or above to the inguinal ligament. It is the differentiated point between the femoral hernia and inguinal hernia. Hope you understand the difference between the direct inguinal hernia, indirect inguinal hernia, and femoral hernia.